I'm Dr. Akanksha. I have done my MD from GMC Bhopal and I have been working as a senior resident in a medical college in Rewa, Madhya Pradesh. So, thank you everyone for giving me this opportunity to present. So, I want to start my slides. Can we just start? Next, please. Yeah. So, starting from what is lung compliance? Lung compliance simply means the ease of distensibility of lung and lung wall. It means how easily you can you can expand the lungs. Uh, Ideal definition is the change in lung volume per unit change in airway pressure. It means if we are changing airway pressure by a unit, either increasing or decreasing, then how much volume change we are expecting to see. It is expressed in liter per centimeter of water. Compliance is basically inverse of the elasticity or elastic recoil. Elasticity is the property of lung to bring it back together. To the property of the lung to come back to its original shape and size, and to it is just opposite of compliance. Compliance is determined by two factors, that is the elastic forces of lung tissue and elastic forces caused by surface tension of the fluid, which is lining the walls of alveoli as well as the other airways, the small airways. Next, please. So this is just a simple question. Like a 3 kg neonate, tidal volume delivered was 14 ml, and pressure required to drive this volume is PIP of 18 and PEEP of 4. So how are we going to calculate the compliance? Compliance simply means change in the volume divided by pressure change, pressure gradient. So tidal volume is 40 and the pressure gradient is PIP minus PEEP. So it came out 1 ml per centimeter of water. In a normal healthy newborn, the compliance is 2.5, 2.5, about 2 to 2.5 ml per centimeter of water. So when do we say low compliance? Low compliance simply means when lungs are difficult to expand or lungs are stiff. So you require high work of breathing to expand those lungs. On the other hand, high compliance means there is incomplete exhalation and incomplete carbon dioxide elimination due to lack of elastic recoil of lung. Lungs are not coming back to their original size due to lack of elastic recoil. Therefore, they are retaining some volume. So low compliance is seen in conditions that reduces FRC and they have a restrictive lung defect, whereas high compliance is seen in conditions that increase FRC and they have an obstructive lung defect. Classical examples are HMD or RDS of low compliance and emphysema or BPD in high compliance. Next, please. So how compliance is different in neonates? In neonates, the lung compliance is decreased. On the other hand, chest wall compliance is increased. So why this is so? Because lung compliance is decreased due to insufficiency of surfactant, whereas chest wall compliance is increased. Basically, it is 3 times more compliant than the lungs because of the cartilaginousness of the neonatal ribs. And neonatal ribs are also horizontal, and the shape of chest cavity is cylindrical as compared to elliptical in adults, and also insertion of diaphragm is more horizontal. And lungs are full of fluid at birth. So at birth, a relatively large amount of pressure swing is required for the first few breaths of life, which only produces about 40 ml of tidal volume. So this example clearly shows that when a newborn is just born, the lung compliance is very low, and therefore a large amount of pressure is required to increase the volume. Next, please. Clinical implications, as we see in RDS, the lungs are less compliant because of lack of surfactant. Therefore, they require more pressure to ensure tidal volume delivery. And when we give surfactant, the compliance is suddenly improved. Therefore, we need to decline the pressure. There is a need to rapid decline in pressures required to deliver the tidal volumes. The same we can see in the graph. In this graph, the green loop is loop of a baby who is having RDS, and after giving surfactant, the loop shifted to the left. That means if we are giving even a smaller amount of pressure is increased, the volume change is very high. Therefore, we need to manage the pressure after giving surfactant because it may further cause volume trauma or pressure trauma. Next. So, as we have seen, chest wall is very compliant in neonates. So, it does not remain sufficiently rigid while deep inspiration. And when baby is having RDS, so a baby is having RDS, so a baby is trying to inhale larger amount of tidal volume. And baby is trying to create a larger amount of negative intrathoracic pressure so that Yes,
Jyoti.
sir.
No,
Sir?
please. No, no, I was speaking to Jyoti to mute herself. Yeah.
Yes, yes. So, in case of RDS, the neonate is trying to inhale larger amount of tidal volume, which requires greater negative intrathoracic pressure, and which further causes the soft neonatal chest to collapse. Therefore, tidal volume is basically decreased because it is functionally limiting the maximum tidal volume possible. So, how baby overcomes this? Baby increases respiratory rate. So, baby is more relying on respiratory rate in order to increase tidal volume in case of RDS. So this is the role of compliance in RDS. Now coming to types of compliance, there are two types of compliance. One is static and other is dynamic. Static simply means the compliance which is measured under static conditions when baby is not breathing, and it reflects only elastic properties of lung. And it is measured by determining transpulmonary pressure change after inflating the lungs with a known volume of gas. And as we have learned earlier also, lung compliance plus chest compliance is equal to the total respiratory system compliance. Next, please. Next, please. Yeah. So in this curve, we can see the green curve. The green curve is back, please. The previous slide. Yes. Huh. So in this picture, we can see the green curve. This green curve is total pulmonary compliance. It includes both chest wall plus lung. On the other hand, the black dotted line is chest wall curve. So it is basic. You can easily see that the chest wall is very compliant. Only increasing a small amount of pressure causes a large amount of change in volume, and after the curve is very straight. Whereas the lung curve, which is a brown dotted line, that is increasing slowly and steadily, and at the 10 pressure it becomes static. So here we can see the chest wall is more compliant as compared to the lung. Next. Here x-axis represents pressure and y-axis represents volume, and the blue line is normal compliance. If it is shifted to the right, it means decreased compliance, and in case of increased compliance the curve shifts to the left. So we can easily see that in the red curve, when we are increasing pressure, the volume is not changing much. It means the lungs are stiff. The same thing happens in RDS. Next. Coming to dynamic compliance is measured during continuous breathing, when baby is continuously breathing. So it reflects both properties, the elastic properties of lung as well as the resistive components. Now coming to what are elastic properties and what are resistive components. Elastic properties, as we can see in this picture, the inherent property of the lung to come back to their original size, original shape. And resistive forces are anything which after inhaling air, the air has to go through a long route to come to the lungs. So that route, that pipe, that is the bronchus and the secretions and bronchioles and the airways, they all constitute resistive forces. In case baby is intubated, the endotracheal tube and the secretions, they all are resistive forces. So dynamic compliance is affected by both as well as magnitude of airflow and neonatal breathing rate. Therefore, in neonates who are having RDS or higher respiratory rate due to any pathology, dynamic compliance is more important. It may underestimate static compliance. Next, please. This is a dynamic pressure volume curve. We can see the curve on the left hand side that x-axis represents pressure, whereas y-axis represents volume. And the lower curve is inspiratory curve. It increases up to a certain point, and then in expiration, it comes back to the normal. The area between this is hysteresis. And the same we can see on the right side. This is a curve. When it shifts to the right, it means compliance is decreased. Next, please. Next, please. Yeah. So in this curve, we can also see that, back please, the previous curve. Yes. So in this curve, let's focus on the inspiratory part of the curve. So on the inspiratory part of curve, initially you can see that when we are increasing pressures, the volume is not increasing much till a certain point, that is the lower inflection point. When you see the graph from the starting to the lower inflection point, you can see that pressures are increasing, but volume is not increasing much because alveoli are recruiting. This is the phase where alveoli are properly recruited, and lower inflection point is the point where, after increasing pressure, sudden amount of volume change is seen, and here all alveoli are open, all alveoli are now happily responding to the pressures, and volume is properly increased. So this lower inflection point is the point where it is supposed to be lower inflection point is supposed to be the minimum pressure required for alveolar recruitment. It is also called as the critical opening pressure of the alveoli.
Akansha, just
And
complete in two
initial rep,
minutes, okay? Dr. Akansha, we're running out of time, so just finish in 2
yes,
minutes.
sir.
Just finish in 2 minutes.
Yes, sir. Sure, sir. Yes, sir. Sure, sir. Next slide, please. Uh, in this picture, we can again see the curve is starting from PEEP because this is a minimum pressure which is important, which is required. And here we can see that this is the alveolar recruitment and airway resistance, the lower part of the curve. And after lower inflection point, the alveoli are after alveoli are properly recruited, the optimal compliance is seen. And we can see the beaking part. That beaking part represents that when we are increasing pressure, volume are not increasing much. It simply means that we are over distending the lungs. So this beaking represents over distension. Next, please. Now coming to C20 by C index, this is an advanced ventilator dynamics. It is which represents it is an index basically coming to C20 by C. What is C20? C20 is the compliance of the last 20% of the inspiration. So let's look at the inspiratory curve on the lower side. When we calculate the last 20% of the inspiration, the compliance of last 20% of inspiration, that is C20. And when it is divided by the whole compliance of the inspiration, that is C20 by C index. It is calculated by ventilator itself, and it is important because when it is less than 1, it means it determines overinflation. And when it is equal to 1, it is normal. And when it is more than 1, it represents tidal recruitment. Therefore, it is a tool which allows the protective ventilation, which reduces the risk of ventilator-associated lung injury. Next, please. So coming to specific lung compliance, it is lung compliance divided by functional residual capacity. Here we can see again on the low FRC, it reflects atelectasis. When FRC is low, then even if we are increasing the pressures, volume is not increasing much. And normal FRC represents the normal compliance. And on the other hand, high FRC represents even increasing a small amount of pressure leads to high increase in volume. It happens in BPD. Next, please. Thank you.